Sort out the trajectories and both are perpendicular, you can then sort out the position. And that's generally fairly straightforward. You just advance or retract the whole system. And now we can think about what exactly we're going to do. If the patient has some of those features that were mentioned in one of the earlier talks, such as scoliosis, lots of previous tenotomies, very large atria, for example, the steering might be a little bit odd, and it's always easier to work that out above the valve. So I quite like doing this. This is a 3D on fast aorta at the top, and I'm withdrawing, advancing, which is pure lateral, anti-clock, pure anterior, and clock is pure posterior. And if any of those movements are diagonal, it's much easier if you know that at the beginning of the procedure, because you can then optimize accordingly. So just to skip through this procedure, this is not a technically complex TIA. This is the kind of anatomy we all dream about. It doesn't come along too much, but it's nice focal P2 prolapse. And so I cross the valve closed, just because I think it's cleaner. I think we're less likely to interact with cords. In this case, I decided to use two devices. This is just on the medial side of the prolapse. Nice leaflet insertion there. So this is 2D biplane I'm using here. And then cross-checking my position in the 3D on fast to make sure we're nicely oriented at 12 and 6. Once we're happy with that, we can close the device and release a little bit of residual prolapse just laterally, which is to be expected. So we can target that with device number 2. So we want to be nice and parallel, nice and close. And one point that I would like to emphasize is the importance of seeing gripper or paddle coming down onto the leaflet. And for that reason, I pretty much always independently grasp, because if you do that, you can be absolutely sure that you have got a good grasp. And so I lower the clasps very, very slowly, and we all watch carefully to make sure that the grasp is a good one. So you see how slowly that right hand grasp gripper came down. Do it very, very slowly, because then you know you've got a good grasp. And then you can optimize the imaging for the other leaflet and drop that one slowly too. We can check the orientation, fine-tune as needed, close the device. And then after every grasp, we check pulmonary veins on both sides, gradient, color flow, LA pressure, and systemic pressure. It's worth checking all of those.